ఫిక్సరా అంటే వాళ్ళు ఉన్నారు కదా మనకి ఎలా తెలుస్తుంది?
అది మనం
మొబైల్ చూసుకోండి. స్ట్రీమింగ్ స్టార్ట్ అయిపోయి ఒకసారి చూస్తారా ఉన్నారా లేకపోతే వాళ్ళకి స్టూడెంట్స్ అదే
ఇంకా జాయిన్
జాయిన్ అవుతున్నారా? అంటే నాలాంటి చూసుకుని జాయిన్ అవ్వమంటారా?
స్టార్ట్ చేసుకోవచ్చు.
ఓకే, ఇది ఇంతేనా? ఇది టూ నెక్స్ట్ ఇది ఇందులో వస్తుందా, ఇలా వస్తుందా?
ఓకే, డౌన్ ఏరో కొట్టేస్తుంది.
Good morning. I am Dr. Prasad, Professor of Orthopedics. From now, I think I will take some classes for you on Saturdays. I don't know whether you guys are attending ortho class regularly or not, but try to be regular from now on. I think one of my colleague has taken trauma classes for you at this hour, and now we try to tell you some other important topics. Basically, orthopedics, we divide it into trauma and cold orthopedics. Trauma, as all of you know, deals with traumatic conditions of bone, that is mainly fractures and dislocations. When it comes to cold orthopedics, you have these infections, arthritic conditions, tuberculosis, rheumatoid arthritis. There are so many other conditions, and bone tumors, CTEV. So we try to begin this cold orthopedics. Out of all that, infections of the bone are very, very important from a theory point of view or from a clinical point of view as well. So bone infection is otherwise known as osteomyelitis. All of you know this itis. Whenever you add this itis to any organ, that indicates that there is some inflammatory component in that. So pancreatitis indicates inflammation of pancreas and pancreatic inflammatory conditions. Similarly, osteomyelitis indicates infection or inflammation in the bones usually. It is mostly by pyogenic organisms. Usually when somebody comes and tells you that this patient is a case of osteomyelitis, then you take it for granted that patient has a purulent infection of the bones. That means the infection which is caused by pyogenic organisms, especially bacteria. But there are various organisms which can cause osteomyelitis apart from these bacteria. And there are several types of this osteomyelitis. So when you say there could be a non-specific one or a specific one, and they can be caused by fungi, and some parasites as well can lead to osteomyelitis. Coming to non-specific, when staphylococcus or streptococcus or pneumococci or Haemophilus influenza or typhoid, all these can cause these infections. But when it is caused by staph, strepto and hemophilia, then it is known as a non-specific type of osteomyelitis. When you say a specific osteomyelitis, then the most common examples of this type would be a tuberculous osteomyelitis or a syphilitic osteomyelitis. Tuberculous osteomyelitis and tuberculous infection of the joints is very, very well known, and it was commonest infection with which patient used to come to our OPDs at one time. But luckily, though the incidence of tuberculosis has not come down. The incidence of bony tuberculosis and tuberculosis of the joints has definitely come down. When I was a postgraduate in the orthopedics, the major cases which we used to see are tuberculosis of the hip joint, tuberculosis of the spine, etc. So even for our examinations, they used to keep the hip joint affliction in tuberculosis as a major main case. So unless you get through that examination of the hip joint, especially from a tuberculous affliction, then you won't get your degree. So it was so common at that time. But nowadays we have seen, thankfully, and we have seen less and less of these cases, but they still do occur. And syphilis is also very rare now. But previously, when we were medical students, if at all any diagnosis is not fitting into any known clinical conditions, then you should think of syphilis as a differential diagnosis, because syphilis and tuberculosis can occur in many forms. So if your diagnosis is not fitting into any conventional things of any system, usually, then you think of tuberculosis and syphilis in our country. Though they are a bit rare, they are not non-existent. So you should make that difference. And coming to fungal osteomyelitis, the fungi which can cause bony infections are actinomycosis and maduromycosis. Actinomycosis, otherwise known as maduromycosis. And some parasites like hydatid cyst, Echinococcus granulosus, I think that is the dog tapeworm. So it could cause this parasitic infestation of the bones. It is a known clinical entity, and a famous tennis personality from India. Hopefully you guys remember Leander Paes. Leander Paes played for India for several years with distinction, and he won several medals for our country in the Davis Cup. Though he may not be so popular or victorious in other events, professional events like Wimbledon and all, but he was very, very successful in team championships, that is Davis Cup matches. He won several matches, and he had this hydatid disease of the brain, and he collapsed while playing tennis in one of the tournaments abroad, and he was being diagnosed as having hydatid disease of the brain, and he was cured luckily. And it's very common, though we think we may not get it, but you do, because most of the vegetables which are grown with this contaminated water, even vegetarians are at risk. So usually this is commonly seen in non-vegetarian people who are on non-vegetarian diet, but even vegetarians are not exempt nowadays. So this is a very rare condition, but you should know for completion's sake that this can occur as one of the osteomyelitic conditions. Coming to the clinical types of osteomyelitis, so you can divide that as acute osteomyelitis, chronic osteomyelitis, and there is one more in between, that is subacute osteomyelitis. Acute osteomyelitis is the acute infection, as the name itself indicates, and chronic osteomyelitis, if you don't manage this acute osteomyelitis, then it will definitely lead to a clinical condition called chronic osteomyelitis. This subacute osteomyelitis is the in-between condition, when the patient's immunity is such that it's not too good or too bad, then this is somewhere in between acute and chronic, so that's called subacute osteomyelitis. And there is one more condition which is known as an acute flare-up of chronic osteomyelitis. You have a patient with chronic osteomyelitis, usually in them the infection is smoldering inside, and as and when the patient's immunity comes down, then definitely there will be an acute flare-up of the chronic osteomyelitis. Usually, the signs and symptoms of chronic osteomyelitis are entirely different from those of acute osteomyelitis. But if the patient develops the signs and symptoms of acute osteomyelitis, a known patient of chronic osteomyelitis, if he develops the signs and symptoms of acute osteomyelitis, then we say that there is an acute flare-up of chronic osteomyelitis. Let us see something about acute osteomyelitis, or otherwise known as acute primary osteomyelitis. Primary means basically occurring de novo in the bone. All of you know about the anatomy of the bone. So here what you have, the bone has a epiphysis and a metaphysis and a diaphysis. And this epiphysis has a covering, it's a covering of articular cartilage. So whenever a bone is in a joint, then the bone has a special covering when it is in a joint, that is called articular cartilage. And here there is a blood vessel entering. This is called a main artery, that is the nutrient artery. It comes inside and gives a lot of branches. And there is another artery called epiphyseal artery, which will supply the epiphysis. So this nutrient artery forms several branches, and several arterioles reach up to the end of the metaphysis. And here the arterioles turn on themselves and make so many hairpin bends. And once that is there, then though it is supplied with a large amount of blood, but the blood supply there is very sluggish. So once there is some stasis, there is not lot of movement there, then all sorts of things can occur at that site. So once bacteria invade this area, then they can colonize here, because there is not lot of activity, so there is nobody to push them out from there, so they colonize there. So in acute osteomyelitis, the location where this initial focus will be metaphysis. Though it is supplied with abundant blood supply, because the vessels are tortuous and the flow is very sluggish, then they tend to colonize there. So the organisms tend to be here, but they don't cross this. This is called a growth plate, which separates the epiphysis and the metaphysis. This is where the longitudinal growth usually occurs. The growth elements are here, this growth plate, and this is a sort of Lakshmana Rekha, wherein the organisms are usually prevented from crossing into the other surface, that is the epiphysis. But sometimes even this bridge can be breached. We will come to that later. So this is in short about the blood supply and the tendency of the organisms to cause the initial infection in the metaphysis. This is the same picture, which is a bit blown up. So metaphysis, as all of you know, that there are two types of bone. One is a cortical bone, and another one is cancellous bone. Cancellous bone is a bit spongy when compared with a compact cortical bone. So this is the cortex. This is the cortex of the bone, and outside it is covered by the periosteum. So this cortex is a intact and bone, and here it is very spongy, because it's not so tightly packed. So metaphysis is having a cancellous bone, and cancellous bone is which is not tightly packed, and the blood vessels are tortuous, hairpin bends are there, and getting U-turns and all. So you have a recipe for disaster here. So bacteria can collect here, and they can do their bit here without any hindrance, so to say. So it cannot usually go beyond the growth plate. So this is the growth plate, and this is the epiphyseal artery, which is supplying the epiphysis. So this is different. Actually, this vessel and this vessel, they are different, and usually this will not breach and go there. Coming to the etiology, so this is a bone here, this is the upper end of tibia by the looks of it. Okay, most of you agree with me. This is the upper end of tibia. These are the condyles. This is epiphysis. This is the metaphysis, and this is the growth plate, or the barrier between epiphysis and metaphysis. And the commonest spread is due to blood, that is hematogenous. So the organisms enter the metaphysis through the blood, and it could be a distant focus somewhere, maybe a dental abscess or some other soft tissue trauma or injury, which may lead to this bacteremia or pyemia. And once organisms are in the blood, so if a few of them come here, then the conditions are very ideal for it. If the body immunity is low, then they colonize here and start the infective process. So this is how the initial focus starts here. So commonest organism is Staphylococcus aureus. All of you know that there are two species of Staphylococci, Staphylococcus aureus and albus. What do you mean by aureus? Aureus, recently we had the Diwali function, and 2 or 3 days before Diwali, they get this Dhanteras, Dhanatrayodasi. Yeah. So all these shopping centers, they go out of way to promote that if you love your wife, buy some gold for her. If you buy that gold, your longevity will be more. So if that sort of sentiment is given, then naturally most of the females are fond of gold. See, my mom and my wife are also included, so don't get me wrong. So once that statement goes out, then all females will flock to these shops to buy this gold. Gold is otherwise known as aureum. So aureus is related to gold. So how gold is related to this Staphylococcus aureus? So most of you must have finished your microbiology. You must have heard about the bacterial colonies and the color of these colonies and all. So the color of these Staphylococcus aureus is golden yellow colonies. They produce golden yellow colonies in the culture. So because these organisms are producing golden yellow colonies, they are called aureus. And some other staph which is producing a white colony, they are called albus. So albus means white. All of you know that albino. So the word coming from that, albino, is white. So that person with vitiligo and all, they call albino. Or Staphylococcus albus is a white colony. So usually commonest infection is by Staphylococcus aureus. But sometimes in some particular age groups, even streptococci, pneumococci, and Haemophilus influenzae can also lead to infections in the bone, and it's very common in kids. So in pediatric age groups, the other organisms can also lead to this infection. So whenever you have a case, then you need to send the pus or the discharge for culture and sensitivity, and isolate the organism and know about the antibiotic sensitivity of that. And the common sites of this infection are ends of the long bone. So this is a upper end tibia. Usually the lower end femur and upper end tibia are the commonest sites of infection, and even they are the commonest sites of bone tumors as well. Why? Because ends of long bones are naturally supplied with abundant blood supply. So if for any tumor cells to come and lodge here, or for any organisms to come and lodge here, there should be more and more blood supply. So if there is more and more blood supply, because these are the growing ends of the long bone, so the lower end femur and upper end tibia. So if you don't know the location of any bone tumor or osteomyelitis, if the question is asked, you can to get away by telling that ends of long bones, especially lower end femur and upper end tibia. So if you tell even without knowing these things, maybe you are right in 90% of the times. So these are the common sites of infection, and Staph aureus is the commonest organism. So without knowing, you are learning more and more PG entrance bits also. So these are some of the PG entrance bits. So if you attend our classes and simultaneously you will be coached for PGMT also. So those are the advantages of attending our classes. Coming to the pathology, how the infection spreads from metaphysis. All of you have seen that the original infective focus was here. So once they are localized here, the various options for them is they can go down into the medullary cavity. So even the medullary cavity can be infected by the organisms going down, or they can breach the periosteum here. They can form a subperiosteal abscess. So they breach the cortex and come and lie beneath the periosteum. And periosteum is very, very tough in the kids. So usually acute osteomyelitis is an infection most commonly seen in children. So the periosteum is thick. That's why it may not breach unless the virulence of the organism is more, or the immunity of the host is very less. It cannot breach the periosteum and go out into the muscle plates. So once the periosteum is breached, then it can form an abscess within the muscles, or sometimes the infection can ascend up. See, this is the growth plate, and usually it cannot breach, but sometimes it can breach and reach the epiphysis as well, or more frequently by, this is very touch sensitive, even without me touching, it's changing the slide. So once the periosteum is broken here, because of the capsular attachment, the pus goes inside the joint cavity. So this is nothing but a joint cavity here. This is the attachment of the capsule. So the pus becomes intra-articular. Then that becomes a septic arthritis. So once infection reaches into the joints, it is called a septic arthritis. As long as it is there inside the bones, it is osteomyelitis. So you should know the distinction between these two, but they are usually signs, symptoms and everything, usually they are similar. So this is the pathology, how the organism can enter various spaces. Coming to the clinical features, as I told you, the commonest age group is a pediatric age group, because patient will be having a lot of physical activity and he may be falling, scratching his knee somewhere while climbing up the wall or falling down. So there may be a soft tissue injury. Our patients usually have these dental problems. So many things can occur which will lead to bacteremia and pyemia, and then osteomyelitis. And once a patient is having osteomyelitis, then there is a high swinging temperature. Fever will be very, very high, and the pain is very, very severe. And there may be a huge swelling, or there may be some swelling will be there. And the signs and symptoms of inflammation, warmth, redness, tenderness, all these things will be definitely there. And with this, the patient may not be able to move the limb just because he has severe pain. But there is no muscle weakness as it is in osteomyelitis. But the patient is unable to move the joint because it is very, very painful. That's why this is called a pseudo paralysis. That means there are no paralysis here. All the muscles are normal, but patient is unable to move because of the severe pain. So when a patient with osteomyelitis comes to the casualty or your OPD, don't be rude to him. Don't be examining him without taking proper care. You should be very, very gentle while you examine. The moment he sees you, he starts crying, because in that they are always irritable, especially with severe fever and temperature. And the moment they see you, then they may start crying and they may not allow you to examine properly. But by looking at the patient and having the history and knowing all these things, you can easily diagnose that it could be a case of acute osteomyelitis. And if you are very gentle and careful in your examination, there you may have a fluctuant abscess under your touch. So if the pus comes out into the planes, muscle planes, then you may have a fluctuant abscess. But if it is still subperiosteal, you may not be able to feel any abscess, but the area will be very tense, because it will be a throbbing pain. Once the pus collects underneath the periosteum and stretching it, and periosteum is supplied with a lot of neurovascular elements. That's why the pain is very severe there, and the knee may be swollen. Though there is no fluid in the knee joint as it is, there is fluid inside. It is called a sympathetic effusion, because there is a lot of inflammatory and infective activity going around the knee joint, and the joint also responds to immobilize by producing fluid, and that is called a sympathetic effusion. Then you need to do the systemic and general examination. That means you need to record the temperature and respiratory rate. All these things you need to go about. Coming to the investigations, once you do some basic blood investigations, blood works, then you will find the white cell count is more, and especially PNML being more, because this is a pyogenic infection, and in pyogenic infections, all of you know that this PNML number will be very much raised, and there will be raised ESR. ESR and C-reactive protein CRP, they usually go hand in hand, and they are more in case of inflammations and infections. So you find increased count and increased ESR and CRP. And if you take blood culture, so before you institute any antibiotic, you take out blood for culture. Or if there is any effusion, or if you drain any abscess, then you send that for culture and sensitivity. Coming to other modalities of infection, the common infection which most of orthopedic patients are undergoing will be a radiograph. But here in the X-ray, the changes will take a long time. That means 1 week to 10 days. But you should not wait. The patient comes to you today with a lot of pain, swelling, inability to move, and high fever, and you suspect acute osteomyelitis. You should not wait till the changes are seen in the X-ray to confirm your diagnosis. There are other ways to confirm your diagnosis. You send the blood work, and the lab reports will tell you that PNML is high, ESR, CRP is high. Then definitely you can institute your treatment. So don't wait till X-rays. So X-rays will take a long time before they show the changes of acute osteomyelitis. What are the changes of acute osteomyelitis? There may be, the earliest change will be a rarefaction at the metaphysis. All of you know that metaphysis is the seat of origin of acute osteomyelitis. So there will be some increased activity which is depicted in radiographs as rarefaction. Rarefaction means being normal bone being white, this will not appear so bright. So there may be some dark areas. So rarefaction means that mineralization may not be absolutely normal. So that means it appears a bit dark. It's a patchy dark. It's not normal. It is abnormal. The moment you see and you know about it, then definitely you can make a diagnosis. And sometimes if the periosteum is involved, then the elevated periosteum, and elevated periosteum always responds by new bone formation. So whenever you see a new bone being formed here and this periosteum being elevated, then you should think that there is some periosteal irritation. It could be either by infection or by tumor. So these are two conditions where this periosteum on irritation will lead to new bone formation. So if the break of the periosteum is there, then the abscess or the tumor can go into the soft tissues. So you should always search for the integrity or otherwise of the periosteum. So the periosteum is elevated and new bone is formed here. So that indicates either infection or tumor. So these are the two common clinical conditions which can lead to this type of picture. So you don't rely on X-ray to make a diagnosis of acute osteomyelitis. Coming to MRI, MRI is another modality wherein you can make a diagnosis much before an X-ray, because once you take an MRI, so this is the end of the bone and this is the intramedullary cavity, and here you can see some amount of pus. So this pus, it started in the metaphyseal area and it is going slowly upwards in the medullary cavity. So once you see a spread of this fluid inside with all the typical features of infection, high swinging temperatures, severe pain, inability to move, and raised blood counts, and with this picture you can easily make a diagnosis of acute osteomyelitis. Or better still, the best diagnosis can be done by a bone scan. In a bone scan, especially with technetium-99, this radioactive substance, it's a contrast bone scan. Once you do this, then definitely there will be increased uptake. So why there should be increased uptake? As we have already seen, whenever there is some inflammation or infection at one part of the body reacts it by means of hypervascular circulation. So this hypervascularity will leads to, once you inject this radioactive substance, because of the hypervascularity, that means increased blood supply to that region. So more and more amount of that technetium-99 comes and pools up here at the site of hypervascularity, that is infection or inflammation. So once that is there, then definitely you can make a diagnosis that there is acute osteomyelitis. So technetium bone scan can give you, even before MRI, the assistance to make a clinical diagnosis. So the investigation of choice, if you have everything, then we should go for a bone scan with technetium-99. So technetium-99 bone scan is absolutely indicative that there is some increased activity, most probably with all clinical features. Don't just go by investigations. Unless you examine the patient, have made a provisional diagnosis, and you have your investigations with you, then only you add 2 plus 2 and come to 4. So just by looking at this picture and patient doesn't have anything, then don't make a diagnosis. So you should always do the investigations, and first you should examine the patient clinically. Then put these two together, then arrive at the normal diagnosis. So once these investigations are in place, then you want to confirm your diagnosis. So how do you confirm the diagnosis of an abscess? The confirmation of abscess anywhere in the body is finding the pus. Unless you see the pus, you don't say that it is an abscess. So this is the gold standard of diagnosis. Pus, getting a pus is absolute indication that there is an abscess there. So how do you get pus from a bone? It is very, very difficult. So then what you can do, you can use a thick bore needle which you can push through the bone and aspirate it. If you are lucky and hit the jackpot, you can get the pus. So if you drain pus, then you are absolutely right in your diagnosis of acute osteomyelitis. If it is not so, if you have an abscess subcutaneously, because the abscess has breached the periosteum and is in the muscle planes, then definitely you can do what is known as incision and drainage. So you incise and drain the pus. So once you do that, then you can collect the pus and send it for culture and sensitivity. You should always send pus for culture and sensitivity unless you know the specific organism and the specific antibiotic for which it is sensitive, your treatment will not be absolutely correct. So whenever you see some pus, drain it and send it for culture and sensitivity. But there are several clinical conditions which have some similarities with acute osteomyelitis. Unless you have these things at the back of your mind, you may not be absolutely correct in all cases that it is acute osteomyelitis. So there are some clinical conditions like acute poliomyelitis. All of you know that poliomyelitis is a debilitating neurological condition where patients will have flail limbs, flaccid paralysis. But it starts as acute, and acute GIT symptoms will be there because poliovirus, all of you know, poliovirus can be ingested. It is by contaminated water, patient ingesting these food or water, then it will go into the gut and does all the tricks. So in acute phase there may be some fever and there may be some muscle weakness, but the muscle weakness in poliomyelitis is real. The muscles are flaccid, but in acute osteomyelitis muscles are normal, but the patient is not moving the limb because of pain. That's why it is pseudo paralysis. But in polio, it is paralysis itself. So you should be able to make that differentiation. Coming to another condition, scurvy. All of you know that scurvy is due to deficiency of vitamin C, ascorbic acid. So in scurvy, there will be some hemorrhages in the bone. That hemorrhage, painful hemorrhages may be seen, and it can be bones become tender, and that can be confused with acute osteomyelitis. But patient may not have so much of fever, and other signs of scurvy may be bleeding from the gums and other things, and non-healing of wounds. All this history will indicate that it could be scurvy rather than acute osteomyelitis. Similarly, septic arthritis. Septic arthritis, if the infection comes into the joint, sometimes without osteomyelitis, patient can have an infected joint. So that is called a septic arthritis. But in septic arthritis also the clinical features are similar, and the joint becomes very, very stiff and immobile because of the inflammatory process and infective pathology inside. So you need to make that distinction. And in acute rheumatic fever also, patient may have a similar picture, but you can easily make out. The symptoms may not be so severe in rheumatic fever as in acute osteomyelitis. And acute green stick fracture. A green stick fracture is a fracture which occurs usually in children. In children, as we have already seen, the periosteum being very thick, it is very difficult for you to break a bone in a chain. Usually the bone bends rather than breaks. So once it bent, then there may be a break at one of the cortex, and the other cortex may be intact. So whenever there is an incomplete fracture, especially in children with thick periosteum, then it is spoken to as a green stick fracture. So patient with a green stick fracture, a patient may come to you, may be brought to you with a pain and tenderness and inability to walk, and there may be plus or minus fever. Fever may or may not be there, and tenderness is there. If when you touch the place where there is a fracture, then the patient will wince. So all these things are there except fever. So fever is definitely seen in acute osteomyelitis, and it is high and swinging. So that will definitely make, but all these clinical conditions you should make up them as a list whenever you want to diagnose a condition like acute osteomyelitis. So all these things are interchangeable. So if you get a septic arthritis, so all these things will be in their differential diagnosis. So similarly, you should know something about all these conditions to rule them out in this particular patient. Coming to the treatment part of it, unless you have a high degree of suspicion, then making a diagnosis of acute osteomyelitis is not easy. And that's what it's similar to saying that eyes cannot see what the mind doesn't know. So if you don't know anything about it, then even when you're seeing it with your own eyes, it will be very difficult for you to interpret what you are seeing. So that's what happens to most of us. We attend most of the classes without employing our mental faculties. We don't hear what's being said there and think about it. We will be thinking somewhere else and being present in the class. So that doesn't help you in any way. Similarly, unless you have a high degree of suspicion that this could be acute osteomyelitis, then making a correct diagnosis and instituting effective treatment will be very, very difficult. And the treatment here should be very, very aggressive. That means you need to start with IV antibiotics. You need to admit the patient. You need to do the blood works. You need to send him for bone scan. You need to send him for MRI if needed. So all these things have to be done at once. So you don't have any time to waste. If you waste time, then it will become more widespread and more complications can occur. So it's like an emergency, acute osteomyelitis. And once the moment you diagnose acute osteomyelitis, you should treat it like hell. So you should admit the patient as soon as possible and immobilize the limb. Why do you want to immobilize the limb? Because it's a very, very painful condition and mere moving the limb will lead to severe pain. So how do you reduce the pain? No amount of analgesics will help the patient if the limb is not immobilized. So if you immobilize the limb, you put a small splint. Suppose patient has osteomyelitis of the one of the forearm bones or leg, then immobilize the leg. If the immobilize the leg, if the leg is not moving, then the pain comes down, then the patient settles down, then the fever also will settle, and your IV broad spectrum antibiotics, because you have sent your blood for culture and sensitivity, and all of you know that it will be more than 48 hours before you get the culture and sensitivity report. So before that, don't wait till you get the report in instituting a antibiotic. You may not be knowing the exact organism which is causing osteomyelitis or the exact antibiotic for which it is sensitive. But there are some antibiotics, all of you know them as broad spectrum antibiotics, which have broad spectrum of activity. That means they are effective against most known pathogen. So this could be this particular pathogen in this particular patient could be one for which this antibiotic is sensitive. So these are mostly cephalosporins, and all of you know the first generation cephalosporin can be given as injectable, and IV you should start with that, and it should be run for weeks. Usually, even in major surgery, we give for 3-4 days, then we switch on to oral therapy. But here, we run it for at least 3-4 weeks, so that even a single organism which is lurking inside that metaphysis, which is though heavily vascular, because of the sluggish blood flow, it is very difficult for the antibiotic to reach each nook and corner and kill all the organisms. Even with this, we are not sure whether we have killed all the organisms. So we should be very, very aggressive while starting the treatment. Then analgesics for pain and antipyretics for the fever. Suppose if the patient is not responding to this treatment, so then what to do? Then you have some surgical procedures up your sleeve. That means if the abscess is localized in the medullary cavity and it is very, very difficult for your antibiotic to go there and breach its wall and act against the pathogen, then what you should do? Then you wait for say 48 hours after instituting your IV antibiotics. Usually by that time, if it is effective, then all the symptoms will start coming down. Patient's pain comes down, fever comes down, then patient will be able to move, because you need not ask the patient and patient need not tell you, because he's a pediatric age group patient, and once the patient is feeling better, you can see by yourself, because patient starts laughing at you. The moment you walk into the room, he starts walking or laughing at you, or he may not be crying by looking at you. So that itself will indicate that patient is getting better. And once you ask the parents, then they will tell you he is playing more, he is using the limb and he is moving the limb, and the pain has come down, he is taking some feeds, fever has come down, all these things. If they say negatively even after 48 hours, then you may have to do this multiple drill holes. This is a surgical option we have. That means we need to take out the pus which is collected inside the medullary cavity. So how do you reach that medullary cavity? So you need to identify the site of maximum tenderness. That means that is the place where this pus is present. So once the pus is present there, then you need to take it out by means of putting multiple drill holes. You see this X-ray here, and here on the left you have an abscess here. So this is a periosteum and abscess outside the periosteum. That's why it is very, very painful, and it is not responding to the conventional antibiotics which you are giving. So then what you, and there is the infection going inside the medullary canal also. Then you open the medullary canal by means of putting multiple drill holes. Once you drill into the medullary canal and there is a pus inside with a lot of pressure, it starts coming out of the bone. Once it starts coming out, once there is some outlet, once the pus comes out, then definitely the vascularity and the antibiotics in your blood which you are giving all these days are instituted now, then definitely they start working and the infection can be controlled. So this is one of the reasons, and this is the surgical treatment for acute osteomyelitis. This is the only surgical option you have. And once you drain the pus, you send it again for culture and sensitivity. Once this is done, then patient will be better immediately within hours, maybe by 6 hours. Patient fever comes down, pain comes down, he starts playing normally. Coming to the complications, if you don't bother about this patient, and if you can't make a correct diagnosis of acute osteomyelitis and treat him energetically in the first instance itself, then it may lead to septicemia, because this is septic focus which is there may be picked up by the capillaries, and once it enters into the circulation, then it can reach anywhere and it may cause abscesses anywhere, or septicemia by itself may lead to pyemia, and which can be fatal, a brain abscess or anywhere. The sky is the limit for for the probability of anything getting infected. So you should not allow it to go up to the septicemia. So the moment you make a diagnosis that this could be acute osteomyelitis, put in an IV cannula and start pumping IV antibiotics. Or it may lead to what is known as chronic osteomyelitis. That we will come to later. And septic arthritis, as we have already seen, if the pus enters from metaphysis through the capsule into the joint, then this is known as a septic arthritis. Or there may be some pathological fractures. Because what is a pathological fracture? Pathological fracture is a fracture which occurs in an abnormal bone. So what is the abnormality of the bone here? Infection is the abnormality. As we have already seen, there will be areas of rarefaction. That means areas of weakness, areas of loss of strength in the bone which can occur because of the proteolytic enzymes produced by the organisms. So they start to lyse what is all in and around them. So the bones can become weak, and sometimes some subacute conditions, maybe the pathological fracture may tell you that there may be some infection lurking in the bone. So it is the other way around. Sometimes the pathological fracture will tell you that there is an infection. So this complication has to be prevented by all means. And all of you know that now there is a growth plate separating metaphysis from epiphysis. So if the infection is virulent, then it will go and irritate the growth plate. And if the virulence is more, even the growth plate may be affected, and there may be growth disturbances. That means if one leg in tibia, right tibia is infected, metaphysis, and the infection goes into the epiphysis through the growth plane. So the right leg, the rate of growth of right leg may be less when compared with the normal left leg. Then there is something called a limb length discrepancy. That means right limb is short and left limb is normally growing. So you have a condition where patient's right limb is short and left limb is normal. So that will lead to inequality in the growth, and gait will not be normal, and there is a lot of stress on all the joints. So many complications can occur. So if you can able to diagnose it early and treat it promptly, then all these complications can be prevented. Coming to another variety, that is called a secondary osteoarthritis. What all we have talked about till now is a primary osteomyelitis. Secondary osteomyelitis is due to a patient, suppose patient has a wound infection, or sometimes patient may have a open fracture or compound fracture. All of you know that an open fracture or a compound fracture is one where the fracture is associated with injury to the skin. So inside there may be 101 pieces, but if the skin is intact, then we will tell this is a simple fracture. So why do you say it is simple fracture when the bone is broken into 101 pieces? We say simple because it's easy for you to treat the fractures. No, it's not easy to treat the fractures, but we know that because the barrier of skin is intact, the chances of infection are minimal. That's why we call it a simple fracture. On the other hand, the other one where skin is breached is known as an open fracture. Open fracture is a fracture with skin open, or the fracture fragments open to the atmosphere. Once the barrier of skin is broken, and as you know, as a matter of fact, what is the largest organ in the body? It's not brain, it's not liver, it's the skin. Skin is the largest organ in the body, and it is the protector of all the organs. So once the skin is breached, then organisms can enter easily. That's why open fractures, complication number 1 is infection. Number 2, infection. Number 3, infection. So infection is so common in open fractures. So a osteomyelitis occurring in a open fractures or because of the wound infection is spoken to as a secondary osteomyelitis. This is not a hematogenous one. It's not coming through the blood. It is due to local factors. Local factors because there is an infection in the wound. There is a wound in the skin which is transmitted to the bone underneath, or there is an open fracture where the bone fragments are open to the atmosphere, so very easy for the organisms to enter. Or sometimes when you operate, see, whenever you are operating on a bone, so you cut the skin, you cut the fascia, you cut the muscles and lay it open to the skin, but sometimes to the atmosphere. Sometimes if the factors inside the OT, usually they are supposed to be very sterile, but there are several factors of which you have no control, then sometimes you may be introducing infection into the wounds. So that can happen very rarely, but it's a known fact. So in those conditions, we call that osteomyelitis as secondary. And as these things are preventable, that means if you take a very good care of the skin wound, or if you take a very good care when you see a compound fracture, or when you are operating in an OT, if you make it very sterile and allow only few people into the OT, and that too very well scrubbed and with all the scrub suits and everything, then definitely the chances of wound getting infected can be reduced. So all these things are preventable conditions. So secondary osteomyelitis is secondary. It is secondary to wound infection or compound fractures or post-operative infection. Coming to chronic osteomyelitis, we will deal with it in the next class. So now what you do is, anyway you are at home, you are not going out anyway, don't go out, stay home and stay safe. Then take out the textbook and read about this. And not only in ortho textbook, your pathology textbooks will be there. Take it out, read what happens in acute osteomyelitis, in chronic osteomyelitis, and after our class, once you go and read about it, then definitely it will be registered in your hard disk somewhere. And even without knowledge, once it is asked sometime in future, uh, in the exams or in the class or in the clinics, then definitely you can retrieve the information and present it. If you don't store it now, and it will be very difficult for you to retrieve them later. And one more thing, all of you know, you must have seen me wearing a mask, cap and all, and you may be laughing. Why there is no one there? We are not in the class. He is the only one in front of the camera. Why should he wear all these things? And usually I wear glove also during while I touch this. But today, unfortunately, I have forgotten it. But I brought my own sanitizer, and once I finish my class, I'll definitely sanitize my hands. So this is to tell you to be very careful. So you make a mask a must. So these 3 M's should make a difference in your life. See, it is very being a medical student. If you are exposed or get infected, then we will become stupid. It's stupidity on our part to go out and get infected and spread it among the people we love. So our family, our friends, you should take very good care of them, because being in this medical profession, you are a health ambassador. So you should be dispensing health education. You should be advising your folks at home, your friends, your people who are working with you, or who are there in your community. So you should be able to advise them properly, ask them to wear the mask properly, and maintain that social distance and hand washing. So it's by no means over. I don't know when you guys are going to come to college. I don't know, maybe this year you are not going to come. So make the best use of the time available to you. How long can you watch these Amazon Prime and Netflix or Hotstar? So you don't avoid all those things, but give some time to the medical education as well. So this is nothing like you pass pathology, forget about it, pass physiology, forget about it, nothing like it. So you should be able to, they are your foundations. So you should be able to build your building on that. You should be adding to that knowledge. It's not that you forget that and add new things. No, that doesn't work in medicine. So you need to read. So unless you have more knowledge, then only your patients will be benefited. Then only you will become a very good doctor. Being a doctor, one among the crowd, doesn't need much effort, but one to look forward to. You should be the best in your business. So try to be the best in your business. Now you have a lot of time. There is no time being wasted for you to come to college and go back. I know that bus ride and all will take a lot of toll on you. It is very depressing and very tiring. But fortunately, you should. That is a positive aspect here. So you are being taught in your own homes. So what more can you ask for? To make the best of it. So you are paying for it. So get the bang for your buck. So go home, read, and don't go out. And even at home, you maintain all these things, and you tell your people how to do this, and be safe. That's what I want to specify again and again. You should be the brand ambassador. You should tell them, and you should make phone calls to all your relatives, friends. So tell them what to do. Unless you tell them, they may not be knowing, they may not be taking it so seriously. So first, to do that, you should take it seriously yourself. That's why I am in this. Okay. So see you in the next class.